Hey guys, welcome to our introduction on geriatrics. Let's go ahead and get started. Our topics for this lesson include epidemiology and demographics, general pathophysiology assessment and management, system pathophysiology in the elderly, common medical problems in the elderly, and trauma with the elderly patient. It's important to point out that as patients age, they become less like one another, um, both psychologically and physiologically. Although some of the functional losses in older age are caused by normal age-related changes, many other result from abnormal changes, particularly disease. In assessing and treating the older patients, it's important to distinguish, when possible, normal age-related changes from abnormal changes. We also know that the purpose of this chapter and this presentation is to present some of the most common physiological changes associated with aging, and then the implications of those changes and the quality of EMS care provided to the elderly patient. We do know that the elderly patient is one of the most fastest growing segments of our population. It includes anyone who's older than the age of 65. Um, and we typically think about these folks back in the 1900s. The population of the United States increased threefold. The number of elderly increasing now is tenfold. Today, in the 21st century, the growing number of elderly patients present a challenge to all healthcare services, including EMS, not only in the terms of the resources that we can provide, but also in the enormous amount of impact that the aging population has on our society. Um, uh, Even in today's setting, where we're dealing with COVID-19, we're definitely seeing that there is a large portion of the elderly that are affected, and because of that, and because of their underlying disease processes, uh, it makes it very difficult for us to provide adequate treatment to that large of a group of patients all at one time. And so we'll dive into that a little bit more as we go throughout this lesson. It's also important to point out population characteristics. We know that the majority of Americans um, are older, and we are referring to that as the graying of America. Um, this is generally going to be looking at patients where we're seeing an absence of major wars or other catastrophic events. And we know that healthcare has improved, and the standards of living have improved since World War II era, leading to longer life cycles. More folks are getting more prolonged care, more life expectancy extensions in their care. And then we also know that by estimates of by 2030, over 70 million people will be 65 or older. And just to kind of think about that, of how much we deal with the geriatric patient with that specific population and how that's going to increase, and the changes that are going to be needed to support the EMS system in our patients. We also know that generology is the scientific study of aging, primarily of aging and aging diseases in humans. Geriatrics is a study and treatments of disease of the aged. Um, so when we think about this terminology of age or being old, we know this is going to account for probably one third of the calls that you're going to see. You're also going to notice that you're going to have a significant amount of societal issues as well. Elderly persons living alone represent one of the most impoverished and vulnerable parts of society. Oftentimes, these patients are living alone, living with a very limited um, financial resources, even social support. And we know that as folks age, we see a deterioration in their independence, and inevitably that they're going to have some assistance. And the question is going to be, do they have access to the care that they need as they continue to age? Again, as we talk about those living environments, we know that the geriatric patients primarily going to be dealing with poverty and loneliness. And this is in normal times. Low incomes force the elderly to choose between such basic needs, necessities such as food or shelter or even medicine. Um, when we're on scene, it's important that we're doing an assessment not only of our patient but of their scene to make sure that the home has a proper temperature, proper cleanliness, the types of foods that they're eating, right? Are they eating food or are they taking their medications? Or do they have to pick between the food they eat or the medications they need to take? And then what does their general appearance look like? Do we notice any types of problems with them functioning on a daily basis in regards to personal hygiene, um, things of that nature. And a lot of the times, these patients are going to fear the loss of their independence, or they're going to consider their illnesses or problems that they're having as a normal part of their everyday life as they age, and that's not always the case. We know that social support is very important for these individuals. This includes doctors that are going to encourage the elderly to interact with other people. We know that one of the leading causes of dementia and Alzheimer's is inactivity of the brain. And so, engaging your brain, being social, interacting, playing games, things of that nature actually will help you hold on to some of those major components that you will lose as you age. We know that it's critical to the mental health and physical well-being that they have social support, and that we include things like live-in nursing care, life care communities, congregate care, personal care homes. There's a number of these. Um, Around here, we see Maplewood, North Point Woods. Those are examples of care centers. Congregate care centers is being an example of like Springfield Towers or Marshall House over in Marshall. And they fear the hospital, and that poses a risk to us because, or to them, I should say, because without going to the hospital, they're not going to be able to get the care that they need, and oftentimes the financial aspect of that can really overwhelm them. When it comes to ethics, in the course of caring for the elderly patients, ethical concerns are going to arise frequently. You're going to be confronted with a lot of different situations. People who are trying to make decisions for their parents or their grandparents or to those that are elderly that they're caring for. A lot of times there's going to be discussion about a patient's competency, if they're able to make decisions for themselves, and then we deal with power of attorney and advance directives or DNR orders. In these types of components, we have to recognize a couple things. Unless a patient is incapacitated, even if they have a power of attorney, they still have the right to make their own medical decisions. Um, a prime example or a scenario that we typically see, we get called for someone who has fallen, potentially may be injured. We arrive, there's multiple family members on scene. We have the patient who's on the floor in need of a lift assist. We get the patient up. The patient says that they don't have any injuries and that they want to refuse care. You then may have someone that's a family member or a power of attorney step in and say, no, I'm need mom or dad or whoever they're caring for, they need to go to the hospital. And unfortunately, that's not necessarily their choice to make. And oftentimes that can be a difficult conversation to have with family, that if the patient, the geriatric patient, refuses to go to the hospital, as long as they're able to demonstrate that they are competent in making sound decisions, and that they're aware of the risks associated with that, they have the right to stay home. They have a right to refuse care, regardless of power of attorney or not. So keep that in mind, that those attributes of control that a power of attorney would have, or someone who's a decision maker on the benefit of the patient, typically the patient has to be incapacitated in order for that to apply. They don't just get to rule over them because legally they have the capabilities to make those decisions. The patient has to be in a situation where they cannot. So just something to kind of think about. Another one is DNR orders. An example would be I have a DNR order and I'm about to die, and I tell you I want you to resuscitate me. And the family says, no, he has a DNR order. Don't work him. If the patient states to you that they are devalidating their DNR order, at that point in time, it no longer is valid. And so you would need to work that arrest, and that would make it for a difficult decision in such a circumstance with family as well. Financial resources for healthcare for the elderly. We typically think about Medicare and Medicaid as our primary forms of insurance for those that are elderly. Typically, they're going to be on Medicare as they get older, and they may have different components of Medicare, different packages they can get for help with uh, ambulance bills or hospital bills or primary care or prescriptions or even dental care, things of that nature can all be provided. But the key to this is that there is still some part, generally speaking, where the patient will have to pay for something. And that can oftentimes make them very hesitant to take on any additional debt or to take on any complications of going to the hospital because they don't want to have that financial burden. And so we oftentimes have to reassure our patients that Um, if they need the care, they need the care, and that's the most important. Another example of universal benefits would be the Veterans Administration or the VA. Um, Now, can you, as a regular provider, take a patient to the VA medical center? The answer is no. You're going to typically have to transport to a local facility. However, it's possible for that patient to be seen later on or be referred back to the VA if necessary. But because of the difficulties in getting patients directly to the VA, they may end up waiting too long to go see their VA doctor and may need emergency services from their home. And that creates another hotspot for conflict, especially if the patient wants to go to the medical center, the VA, and we can't transport there. There are some healthcare alternatives that we can be aware of. We know that hospitals have shifted patient care more and more at home, and we're seeing this as we begin to expand nationwide the community integrated paramedic uh, scope, which will primarily allow for more home care to be done rather than just emergent care. We also know there's a large hospice movement to help make those patients at the end of their life as comfortable as they can be. And these trends typically have a heavy impact on EMS personnel. Um, they're asked to perform care that we're generally not trained to do. It's not routine emergent or in the scope of practice of a paramedic. Um, but we also know that we can develop relationships with long-term patients where you can actually begin to develop um, a lot of really good relationships um, with these elderly folks because you're seeing them on a regular basis. There are some prevention self-help techniques that you can implement. One of the areas that's great for the elderly are senior centers. It gives them a place to gather, gives them a place to interact with each other, to make sure they feel that they have a purpose in their life that will help them thrive. We also know that religious organizations or church groups, things of that nature, are going to be a great way for them to be able to socialize and interact. There are a multitude of national and state organizations, as long as governmental agencies that help represent those of the geriatric population. Now, as part of those prevention strategies, we've talked a lot about previously about ways in which we can be attentive to the scene, kind of keep our head on a swivel, have good situational awareness to protect our patients, not only for the emergency that we were called for, but for future occurrences that we may need to provide some support for. Um, some of these issues and strategies are relatively simple. Exercise right, so we want to make sure that these patients are getting as much cardiovascular activity as they can. 20 to 30 minutes 3 times a week would be ideal. Nutrition is another important aspect of that. It's going to vary from group to group, but generally low fat, high fiber, reduced sugars, moderate proteins, adequate calcium for bone strength, especially for women who typically deal with issues associated with losings of vitamin A or vitamin D. We also know that alcohol or tobacco use should be limited, if not consumed at all. And then sleep. Typically, they're going to need anywhere between 7 to 8 hours of sleep. A lot of studies have shown that we need more sleep when we're younger, and as we get older, we don't necessarily need as much sleep. And so we want to see that these folks are actually resting. We don't want them sleeping around the clock, though, as that won't necessarily be good either. We know that disease accidents, that's a big one that we're going to be there for, watching for rugs or handrails, slippery surfaces, any type of impaired lighting at night or hazards for travel or trip hazards. Any of those things we need to try to address as on scene as part of our care. We need to handle the emergency first, but those are additional things that we may need to come back to later on to help that patient prevent a major injury. Dental checks are important as well, along with mental and emotional checks, but pharmacologic are probably some of the most important. When we deal with these pharmacological, we're talking about regular review of their prescription medications, along with what over-the-counter medications that they're taking, and primarily focusing on any potential interactions of those those medications, or even the pneumonia vaccine for that matter. So we want to make sure that since we know they're taking multiple medications, that they're having that polypharmacy, we want to make sure that they're not mixing things they shouldn't be taking or taking too much of one drug or another. And this is even more prevalent now that we're seeing patients shop around for the lowest cost to fill a prescription. So they may have a prescription at Walgreens and a prescription at Rite Aid and a prescription at Meijer, and all three of them are going to be the best deal they can get. But if they accidentally get one filled at another pharmacy twice, they could potentially be taking the same medication twice. So just some things to kind of think about. Um, Overall, the key things that I want to discuss for this introduction is going to be we know that the means of survival rate for the older person is increasing. We know that the birth rate is declining. We know that there has been an absence in major wars or catastrophes, and that the healthcare and standards of living have improved so significantly since World War II that we're expecting there to be a lot more population of the elderly as we continue to move forward. And so we're going to explore these areas in more detail as we get into some general pathophysiology, assessment, and management, and then even more so as we get into specific emergencies. So go ahead and sit back and continue to work through your lesson, and we'll see you here on our next lecture video. Thanks, guys.